Assalamualaikum doctors. In this video I am discussing about kidney transplantation or renal transplantations. It comes on abdomen examination. So do the abdomen examination, we find that. So look at the pictures we are seeing, that is third kidney transplantations. There are small lots of that is midline laparotomy scar and also drainage tube, I think ileostomy, colonostomy. These are lots of scar marks, small scar marks. So in this picture what I see multiple scar marks for kidney transplantation, right sided, left sided, 3 and small scars, and there is a midline laparotomy scar. Any abdominal complications, abdominal cause maybe, we'll explain like that. So in renal transplantation, what we find? General examination, the child is pale or jaundice, small for age, no clubbing, multiple cannulation scars. So in hand we find multiple cannulation scars. NG tube or gastrostomy tube, rickets. Rickets we find like hand swelling. There is bowing of the leg we can find, because renal rickets is one of the knock knee in a kidney transplantation patient. Portaket we can be find, portaket on the left side of the chest we find, where we give the medications. Long line, AB fistula on the hand we find. Peritoneal dialysis catheter or scar. Okay, so peritoneal dialysis catheter scar, urinary catheter, hypertension, signs of steroid and other chemotherapy toxicity. So signs of steroid toxicity, that means the child has maybe excessive hair, hirsutisms, there is a interscapular pad of fat, and abdomen also there is triamark, and obese child mainly, double chin. Local examination we find scaphoid abdomen, nephrectomy scar in the renal angle, like our pictures we are finding nephrectomy scar in the renal angle, scar above this mass of implanted kidney in the right iliac fossa. So there is scar above the mass. There is a mass we can find below the scar because of the implanted kidney. Okay, so that is the main presentation we can be find in examinations. And investigation of the chronic renal failure, what we do? Renal function test, albumin creatinine ratio we do, ABG and electrolyte, especially the potassium. So we are doing renal function test, albumin and creatinine ratio, ABG and electrolyte, especially the potassium. GFR we are doing chronic renal failure GFR when less than 60 ml per minute per meter square for more than 3 months. That is full blood count we do. We find anemia of chronic disease, normocytic normochromic anemia, iron profile for iron deficiency anemia. Coagulation profile we do, calcium profile and vitamin D. D we are doing vitamin D deficiency. Urine analysis, 24-hour urinary protein. Radiology we are doing abdominal ultrasound, KUB for size and shape of the kidney and calculi. Damsa scan, CUG, X-ray of the wrist for rickets, and renal biopsy. So they ask how management. First we are telling that we take the history, and then the management we are telling that renal function test we do, ABG, electrolyte, albumin creatinine ratio, GFR we do, full blood count we do, coagulation profile we do, calcium and vitamin D level, urine analysis we are doing, radiology we are doing, abdominal ultrasound and KUB, Damsa scan, MCUG, X of the wrist for rickets and renal biopsy. Okay. So they can ask us that what is the indication of renal transplantation. It is an end-stage renal disease. Secondary to end-stage renal disease we do. Secondary to number 1 congenital like polycystic kidney, dysplastic kidney and Alport syndrome. So our child is small, polycystic kidney disease, dysplastic kidney disease and Alport syndrome. Acquired are like obstetric uropathy, any malignancy, SLE and nephritis. Acquired are obstetric uropathy, malignancy, SLE and nephritis. What is the indication of hemodialysis? So hemodialysis we can find volume overload, uremic encephalopathy and uremic pericarditis. So volume overload, uremic encephalopathy and uremic pericarditis. Complication of kidney transplantation, what are that? Rejection can be present. Infection like cytomegalovirus and pneumocystic PCP are the common cause of death in the first year of life after transplant. Obstruction, hypertension, electrolyte disturbance, bleeding, malignancy, complication of the chemotherapy medications. If the cause is autoimmune disease, relapse may occur and reject the transplanted kidney. So complications are rejections, infection like CMV and PCP, obstruction, hypertension, electrolyte disturbance, bleeding, malignancy, complication of the chemotherapy medications. If the cause is autoimmune disease, relapse may occur and reject the transplanted kidney. Management, I will involve the multidisciplinary team, nephrology, endocrinologist, dietitian, psychotherapist, social worker. So nephrology, endocrinology, dietitian, psychological support and social worker. Treatment of reversible kidney injury. Reversible kidney injury, first we do like prevent progression, control the blood pressure, maintain the normal electrolyte, treatment of infection and anemia. So first we prevent the complication of progression like maintaining blood pressures, maintaining normal electrolyte and treatment of infection and anemia. Then treatment of complication like salt and fluid restriction, hyperkalemia, these are. Hypertension, we are giving diet, diuretics, ACE inhibitor. Acid-base balance, we are giving acute acidosis, we are doing dialysis. Chronic acidosis, that is dialysis. So acid-base balance dialysis, we are doing renal osteodystrophy. There is low phosphate diet, phosphate binders, calcium and vitamin D3. Failure to thrive, we are giving nutrition, growth hormone, correct the acidosis and anemia. Nutrition, avoid the protein restriction, potassium phosphate diet, take iron, zinc, water, vitamins. And anemia, erythropoietin, iron and folate we are giving. And renal kidney, that is dialysis and transplant. Okay, the advice what we give, some advice is very important for kidney transplantation. Avoid nephrotoxic drug, NSAID, paracetamol is safe. Okay, avoid nephrotoxic drug, NSAID, paracetamol is safe. Then avoid dehydration, give plenty of fluid. Avoid infection like with varicella. If infection with symptoms, so IV cyclobur, no symptoms, so immunoglobulin varicella zoster. Live attenuated vaccines are contraindicated. Prophylaxis with the cotrimoxazole for pneumocystic carinii and valganciclovir for cytomegalovirus, which are the most common cause of death. So we are giving prophylaxis with the cotrimoxazoles. Then clinical review regarding the blood pressure, growth, jugular venous pressure, lab testing and regular monitoring of the creatinine versus baseline creatinine. So advise are avoid nephrotoxic drugs, the NSAID, but paracetamol is safe. Avoid infections, drink plenty of fluid. Prophylaxis can be take cotrimoxazole because of the PCP and the cytomegalovirus. Then what live attenuated vaccine is contraindicated, that is we keep in our mind. And clinical review follow-up like blood pressure, growth, jugular venous pressure, lab testing and regular monitoring of the creatinine versus baseline creatinine. What are the causes of fever in patient with renal transplant? Fever are first of all infection, rejection, UTI, obstructive uropathy. If on dialysis, rule out the peritonitis. If diarrhea, rule out of the hemolytic uremic syndrome, gastroenteritis. So the causes of fever in patient with renal transplantation are infection, rejection, UTI, obstructive uropathy. If on dialysis, rule out the peritonitis. If diarrhea, rule out the hemolytic uremic syndrome or gastroenteritis. So how can we present after examinations? Today I examine, suppose Ali is an 8-year-old. I do his abdomen examinations. He is well looking, not in pain or distress, well communications present, and height and weight like he looks small, though I want to plot him on the appropriate growth charts. Then I want to tell that I find there is a pallor, he is pale, jaundice. There is no any stigmata of chronic any liver disease, no organomegaly by palpations, and there is no ascites. Okay, and the positive finding what I find there is suppose he is pale, jaundice, he is small for age. On abdomen, I find there is, if portacath, I will tell that portacath, gastrostomy tube, anything what I find. I tell, and there is in this picture there is a scar, 3 big scar I see. Maybe kidney transplantations, one big laparotomy scar, maybe any abdominal complications. There are small, lots of small scar, maybe drainage tube, colonostomy, ileostomy, gastrostomy or drainage scar, peritoneal dialysis. So these are. So putting together, it's a case of renal transplantations and any chronic renal failure case, renal transplantation. So this is all about renal transplantations. Thank you.